Welcome back, everyone, fellow eye doctors. Anterior uveitis. I always feel like I'm playing detective with these cases. It can be tough.
Yeah, no, it's a real puzzle sometimes. Figuring out the cause is one thing, but then, we have to figure out the treatment. It's not a one-size-fits-all kind of thing.
Exactly. So to help us navigate this whole thing, we're going to be taking a deep dive into this review article. It's called Anterior Uveitis for the Comprehensive Ophthalmologist. You can find that linked in the show notes.
Yeah, this article, it's really great, really practical. It lays out like a really useful step-by-step approach to anterior uveitis, which is, what we need in our busy clinics.
For sure. Okay, so first off, I was kind of blown away by this fact that uveitis is responsible for 10 to 15% of blindness in developed countries. That's a lot.
It is. It's a lot. And it just goes to show you how important it is to diagnose and treat it early. And it's wild how many things can cause it. The article, it breaks it down into three main categories. You've got infectious causes, non-infectious causes, and then there's this category, the masquerades.
Masquerades. Okay, now that sounds interesting. So, like, those patients that come in and it looks like uveitis, classic uveitis, but it turns out to be something else completely different.
Exactly. Yeah. Sometimes, you get fooled because other conditions, they mimic the signs and symptoms of uveitis. So you got to be really careful, Don't want to jump to any conclusions.
Right. So before we even get into all that, the diagnosis and all that, let's talk about who are actually likely to see with anterior uveitis. What does the epidemiology tell us?
Well, anyone can get it, but we tend to see it most between the ages of 30 and 60. And there are a few interesting risk factors that, we should keep in mind.
Like smoking, right?
Yeah.
Smoking's bad for just about everything in the eye, as I recall.
Oh, absolutely. Smoking it increases inflammation throughout the body, and that includes the eyes, of course. Ethnicity also seems to play a role. Certain groups are just more likely to have specific types of uveitis, like, for example, HLA-B27 associated uveitis. That's more common in Caucasians.
Yeah, HLA-B27, that gene, just to remind everyone, HLA-B27 is a gene that's associated with certain autoimmune diseases, like ankylosing spondylitis, and that can increase the risk of uveitis.
Exactly. And it's a perfect example of how, a problem somewhere else in the body can end up showing up in the eyes. Oh, what's interesting? Pregnancy. It actually seems to protect against uveitis flares, especially in the second and third trimester.
Wait, really? So pregnancy can actually be like a good thing for uveitis? That seems kind of counterintuitive. Why would that be?
Yeah, it's thought to be because of the hormonal changes that happen during pregnancy. It could be that they're suppressing the immune response, the one that actually triggers uveitis. So,
Yeah.
so that's kind of cool. But, pregnant women can definitely still get uveitis. But it's something interesting, right? And on the other hand, conditions like preeclampsia and eclampsia, those can happen during pregnancy, and those can actually increase the risk of uveitis. So if you have a pregnant patient with eye inflammation, it's really important to get a very thorough history and, consider all these things.
Absolutely. It's like a puzzle, connecting all the dots.
Mm.
Okay, so let's say we've got this patient that walks into the clinic and they have this suspicious red eye.
Mm-hmm.
What are the key signs that really scream anterior uveitis?
So you've got the classic triad, right? Pain, redness, and photophobia. But here's the thing. Not all cases will present like that. Some patients might just have really mild symptoms or even no symptoms at all.
So they could have anterior uveitis, but their eye looks totally normal.
It's possible, especially if it's a chronic condition, something like Fuchs heterochromic iridocyclitis, FHI. They might just have these subtle little signs like maybe a few cells and flare, but no pain or redness or anything.
So you can't just rely on the patient's symptoms. Okay, what about the exam? What should we be looking for there?
Well, the first thing is to make sure it's not something else causing the red eye, like conjunctivitis or keratitis or anything like that. And then careful slit lamp exam. It's essential. You're looking for any signs of inflammation in the anterior chamber. Cells, flare, keratic precipitates, those little white blood cell clumps on the back of the cornea.
And of course, the dilated fundus exam, that's a must. Got to rule out any posterior segment involvement, right? Because if there is, we're sending them to retina.
Oh, absolutely. Can't emphasize that enough. That dilated fundus exam, it can really save you sometimes. You might find something back there that you wouldn't have seen otherwise.
Okay, so we've got our patient's suspicious eye, ruled out other causes, exam points to anterior uveitis. Now, the big question, what about the workup? Do we just go ahead and order every test under the sun?
Well, that would be That would be easy, wouldn't it? But, realistically, it's just not practical, not to mention expensive. And the review article, it actually advocates for a tailored approach. So you start with the most common and the least invasive tests, and then you only escalate if you need to.
Okay, so it's kind of like climbing a ladder, one rung at a time.
Exactly. And the first rung on that ladder is usually going to be some basic blood work.
Like a complete blood count, CBC.
Well, not necessarily. The article, it talks about this really fascinating study, the ULIS trial. It's the only randomized controlled trial that's looked at the diagnostic workup for uveitis.
Oh, wow, a randomized controlled trial. That's the gold standard, right? What did they find?
So they actually found that routine blood work, like a CBC or ESR or CRP, those didn't really tell us much. What was really helpful were things like HLA B27 typing, serum ACE levels, testing for syphilis, and chest imaging.
So we should really be focusing on the tests that, are most likely to tell us something based on what we're looking for, instead of just like a general panel.
Exactly. The ULIS study showed that the targeted approach, it's not only more efficient cost-wise, but you also get just as much information as you would if you did all the tests.
Well, that's good to know. That's reassuring. So we can be efficient without, missing anything.
And it's better for the patients too, right? I mean, who wants to, go through a bunch of unnecessary tests?
Okay, so we've climbed the first rung of our diagnostic ladder. We've got some initial results. Now what? This is where the real detective work starts, right? You got to look at the results and then, decide what to order next.
Yeah, for sure. It's like putting together a puzzle. Okay, let's say you've got this patient. They have acute unilateral anterior uveitis, and their IOP is through the roof.
Ooh. Okay. Yeah, red flag for me. I'd be thinking Posner-Schlossman,
Sure.
or maybe even herpes simplex keratouveitis.
Right. And then, you might want to do an anterior chamber tap, get some PCR testing done, make sure you got the right diagnosis.
Yeah, makes sense. But I'll be honest, I always kind of hesitate to do an anterior chamber tap, especially if it's a younger patient. Any advice on how to talk to them about it?
I totally get it. It's not the most fun procedure, but it's really important to just explain to the patient why you're doing it. Emphasize that it's going to help you figure out exactly what's going on, and that can save them from a lot of unnecessary treatment down the road.
Yeah, no, that's a good point. A little discomfort now can save a lot of trouble later. Speaking of treatment, once we've figured out what we're dealing with, what's the best approach to managing this anterior uveitis?
Well, the main thing is you got to control the inflammation. You want to prevent vision loss, and for that, topical corticosteroids. That's our go-to.
Yeah, usually our first line, right? But those corticosteroids, they can be a little tricky sometimes. Great for knocking down inflammation, but they come with those side effects.
Right.
Elevated IOP, cataracts.
Exactly. So, use them carefully and taper them off as soon as you can. The article, it recommends the stepladder approach to treatment. Start with the topical corticosteroids, and then you only go up to the other options if you have to.
So what if they're not responding to the topical steroids? Or, if they can't tolerate them for whatever reason,
Yeah.
what's the next step on the ladder?
Periocular corticosteroid injections. Those can be a good option. You get a higher concentration of the medication right where the inflammation is, and it can really help to quiet things down.
Okay. And what about systemic corticosteroids? When do we use those?
You usually only use those for really severe cases, or if the patient has some underlying systemic condition that needs to be treated systemically, like sarcoidosis or Behçet's disease.
Okay, so we've got the corticosteroids,
Yeah.
but then there are those patients, right? The ones who don't respond to steroids or they keep having these recurrent episodes. That's where immunomodulatory therapy comes in, IMT.
Right. IMT. It can be a game changer. It helps to kind of, dampen that immune response that's driving all the inflammation. And that can help us control things long term without needing to use so many corticosteroids.
So what are our options with IMT? What are the main medications we can use?
Antimetabolites. Those are usually our first choice. You've got methotrexate, mycophenolate mofil, and azathioprine. Those are the big ones.
And how do those work? What do they actually do?
Basically, they mess with DNA synthesis in cells that are dividing really quickly, like the immune cells that are causing the inflammation.
Oh, so they're like putting the brakes on those out-of-control immune cells. I remember learning about those in residency. But I'll be honest, I haven't used them much in practice. Any tips, anything you can share about using them?
Sure. I mean, first of all, you got to be aware of the side effects, know what to watch out for. So make sure you're checking liver function tests, complete blood counts, creatinine levels, all that.
Right, right. Important point. We don't want to solve one problem and create a new one. And I'm guessing it's a good idea to co-manage these patients with a rheumatologist, right?
Definitely. It's a team effort. They can help with dosing, monitoring, and they can also just, give you a better picture of the patient's overall health.
Teamwork makes the dream work, right? So you said antimetabolites are usually the first choice. What if those don't work? What are other options?
Then we might think about biologics, like the TNF inhibitors. Adalimumab is one. And there are biosimilars available now, too. These work by blocking a specific molecule, TNF-alpha. It's one of the main players in inflammation.
So let's say we've tried like methotrexate, an antimetabolite, and it's not doing the trick. Uveitis is still flaring up. Or maybe the patient can't tolerate the medication. Is that when we'd send them to a uveitis specialist?
That's definitely a good time to consider it, especially if you're not comfortable managing biologics yourself.
Yeah.
Uveitis specialists, they have a lot of experience with these medications, and they can really fine-tune the treatment for each individual patient.
That makes sense. Now, what about complications? We talked about CME earlier. Are there other things we need to be watching for?
Yeah, for sure. CME, cystoid macular edema, that's one of the most common complications of anterior uveitis. And it can definitely lead to vision loss if it's not treated.
So how do we manage CME when it happens?
Same idea as with the uveitis itself. You got to control the inflammation. So topical corticosteroids, NSAIDs, those are our first-line treatments. And you might need to increase how often you use them, depending on how bad the CME is.
And if that's not enough?
Then you might think about those periocular corticosteroid injections, like we talked about before.
Okay, so kind of a similar stepladder approach. Start with the least invasive, and then go up from there if you have to. Anything else? Are there other complications we should be thinking about?
Glaucoma, that's another big one. Uveitis can cause the IOP to go up, and there are a few different ways that can happen. So you got to keep a close eye on these patients, literally. And be ready to start treatment if you need to.
And then there's cataracts. Always a concern with those corticosteroids.
Yeah, that's right. And sometimes, you might have to remove them surgically. But the important thing is make sure the uveitis is quiet before you do any surgery.
Yeah, I mean, operating on an inflamed eye, that just sounds like a recipe for disaster.
Exactly. You want to minimize the risk of complications. And that means getting the uveitis under control first.
So we've covered a lot today. Epidemiology, diagnosis, treatment, complications. It feels like we've really gotten a good handle on this whole thing.
Yeah, I agree. Hopefully everyone listening is feeling a little bit more comfortable with anterior uveitis now.
I know I am. That stepwise approach for both diagnosis and treatment, that really helps to, make it feel less overwhelming.
And remember, the key is early diagnosis and treatment. That's how we preserve vision and improve quality of life for our patients. So, keep an eye out for those subtle signs. And don't be afraid to consult with a specialist if you need to.
Well said. And for everyone listening, if you want to learn more, we've got the link to the full journal article in the show notes.
It's a great article, lots of good info. There are even some tables and algorithms in there that you can use in your practice.
And if you're enjoying this deep dive into anterior uveitis, we'd love it if you'd leave us a 5-star rating. Yeah. And share the episode with your colleagues.
Yeah, spread the word. And don't forget to follow the podcast. We've got more great deep dives coming up on all sorts of ophthalmology topics.
We do. But for now, we'll leave you with this thought. How can you use what we talked about today to improve patient care in your own practice? Think about it. Talk to your colleagues. And let's all work together to keep those eyes healthy and happy. So we're back. We've been talking all about anterior uveitis this whole time.
Yeah, from all those different causes and how it shows up to, figuring out what it is and then how to treat it.
Right, exactly. And I think we've covered a lot of ground.
We have a lot of ground, and hopefully everyone listening is feeling a little bit more ready to handle those uveitis cases now.
Me too.
Yeah.
For sure. Okay, so before we wrap things up, how about we just go over some of the key points one more time?
Yeah, sounds good. I think the most important takeaway for me is just that, anterior uveitis, it's not the same for everyone. You have to, really listen to the patient, do the right tests, and then the treatment has to be specific to that person.
So no more just ordering every test in the book, huh?
No. The that ULIS study, remember, that showed us that if you just do the tests that make sense, that are the most likely to help you, you get just as much information, and It's way more efficient.
And cheaper, too,
Oh,
right?
absolutely. Cheaper for everyone. And don't forget about working with other doctors, especially if it's, maybe connected to something else going on in the body, or if you're thinking about using IMT,
Yeah, that rheumatologist can be your best friend.
they can. Teamwork is, it's so important in these cases.
For sure. Now, if anybody wants to, review anything or maybe dig a little deeper, you can always go back to the journal article. We got the link for that in the show notes.
Yeah, and it's a good one. Really helpful. They even have some like tables and charts and things, algorithms
Yeah.
that you can use in your practice. Really practical stuff.
So if you've been enjoying this deep dive on anterior uveitis, do us a favor, okay? Leave us a 5-star rating and, tell your colleagues about it.
Spread the word. And don't forget to follow the podcast so you don't miss any of our other deep dives. We've got some great episodes coming up on, well, all sorts of stuff. Glaucoma, retina, new technology, you name it.
All that good stuff.
Yeah.
Okay, but for now, we're gonna leave you with this. How can you take what we talked about today and actually use it to make things better for your patients? Think about it. Maybe talk it over with some of your colleagues, and let's all work together to take care of those eyes, keep them healthy and seeing clearly. See you next time.